So the topic of my presentation is management of Cubitus virus by Ilizarov. And we published a paper on this last year in JPOB in 2020. To introduce, a Cubitus virus is an inward inclination of a supinated forearm on an extended elbow. And it's a most common complication of supracondylar fractures in children. And there is a varus hyperextension and internal rotation of the distal fragment. We treat it by osteotomy when there is an unacceptable cosmetic appearance or there is a functional impairment. The principle of surgery is in cubitus varus, there is inadequate reduction of the fracture, that is medial displacement and internal rotation of the distal fragments. So we correct it by the surgery, we correct the varus tilt and the rotation. Now the problem is there are many osteotomies described in the literature to treat the cubitus varus. It means there is a no gold standard or definitive treatment. Commonly performed osteotomy is lateral closing wedge osteotomy and internal fixation, which many times lead to poor cosmetic appearance due to the lateral condylar prominence, and many times there can be recurrence of the deformity due to the tendency of the distal fragment to angulate in varus after internal fixation. And obviously, there is quite a good amount of exposure. To overcome it, Ilizarov gives a good solution which overcomes the limitations of internal fixation. You can always have post-op adjustments to have a complete accurate correction. It is obviously minimally invasive and you can start the early mobilization. If we talk about the patient, we had 32 patients and our inclusion criteria was post-traumatic cubitus varus more than 10 degrees and age less than 18 years, and there was a surgical correction done using the Ilizarov external fixator. Our mean age was 9.2 years. Pre-op, in the clinically, we measure the carrying angle, range of motion, internal rotation deformity, and the neurovascular assessment. On the X-ray, we see the CORA, the HEW angle, and the LPI, that is lateral prominence index. The carrying angle is the angle between the lines joining the midpoint of the wrist and the antecubital space and the humeral head, with elbow in full extension and wrist in supination. Normally, it varies from 5 to 15 degrees, and mean in males is 6.5 degree and in females is 12 degrees. So this is how we measure the carrying angle by a goniometer. To measure the internal rotation deformity, we follow the procedure given by Yamamoto et al. In this, the patient bends forward slightly and place the forearm in the back and the elbow extended flexed 90 degrees and the shoulder, it is hyperextended. With elbow as a fulcrum, forearm is lifted off the back to have maximum internal rotation of the humerus. Normally, forearm cannot be brought up from the back. Usually the forearm keep touching the back. But in cases of cubitus varus, the forearm is lifted off, forming an angle which is amount of the internal rotation deformity. HEW is the humerus elbow wrist angle. It is the angle between the anatomical axis of the humerus and the forearm. On the AP radiograph of both upper extremities with elbow extended and forearm supinated. The anatomical axis of the humerus, we find it by drawing the mid-diaphyseal line. To have the anatomical axis of the forearm, we have to draw two transverse lines. First, at the level of the bicipital tuberosity of the radius, and second, at the level of the maximum interosseous space between the radius and ulna. And if we join a line connecting the midpoint of these two transverse lines, we get the anatomical axis of the forearm. And where these two lines meet is the point of intersection is the CORA. And the amount of deformity is the sum of this varus deformity plus the HEW angle on the normal side. Because normally it's valgus and we have the varus. LPI is the lateral prominent index. Many times you measure it to see how prominent is the lateral condyle. Even you can measure the rotational deformity on the CT. If you draw this line from the humeral head and you go down and a line, a z-axis in the distal end of the humerus, there is an angle between these two lines, which is the amount of the humeral rotation. Normally it is 44 degrees, and in cases of cubitus varus, it will be increased. If we go to the surgical details, We always make a pre-constructed frame which consists of two full rings of appropriate size. The distal ring is at the level of the epicondyles and the proximal level ring is at the level of the anterior axillary fold. We apply the juxta-articular hinges anteriorly and posteriorly in the sagittal plane. The hinges are loosened to position this distal ring parallel to the elbow joint line to mimic this deformity. And there's a distraction rod on the medial side. To start with, first, the step one is we pass an olive wire from this posterolateral to the anteromedial surface. Step two, we apply the pre-constructed frame on this olive wire. Step three, at the level of the proximal ring, a second olive wire is passed from the anterolateral to the posterior medial direction. Step 4, we tension this first olive wire. Step 5, we tension this second olive wire and our basic frame is ready. Step 6, we reinforce the frame by putting a third wire from the medial epicondyle from posteromedial to the anterolateral. Ulnar nerve is palpated here and pushed away. Step 7 is this tensioning of the third wire. Step 8 is pin application in the distal ring. We do it by drilling with a 2.5 mm drill bit for half pin in the distal ring at this lateral condyle, posterolateral to anteromedial. And we insert the 4 mm half pin at the lateral condyle from posterolateral to anteromedial direction. Step 10, we apply a pin in the proximal ring. For this, we put a 1 or 2 hole wrencho block in the proximal ring. We drill with a 2.5 mm drill bit through a protective sleeve from anterolateral to posteromedial direction. Step 11, we insert a 4 mm half pin from anterolateral to posteromedial direction. Step 12, the second half pin is applied in the proximal ring. For this, a 2 hole wrencho block is applied upward to the proximal ring and we drill with a 2.5 mm drill bit through a protective sleeve from lateral to medial. An insertion of a 4 mm half pin lateral to medial. Now our steps are complete. Distally, we have 2 wires and 1 pin, and proximally, we have 1 wire and 2 pins. Now we loosen the hinges before the osteotomy. We loosen the anterior hinge and we loosen the posterior hinge. And we perform an osteotomy by drilling from this lateral to medial direction by a 2.5 mm drill bit. We drill from the osteotomy lateral to medial, anterolateral to posteromedial, and posterolateral to anteromedial. Then we do a supracondylar osteotomy, direction lateral to medial, cutting both the anterior and the posterior cortices. So this is the basic surgical steps by which we apply the frame and we do the osteotomy. Post-op, we start the exercises from day 1, and for the correction, we start the gradual distraction from day to 5 to 7, depending on the age of the child, usually 4 times a day. And usually we do 3 mm per day distraction at the motor unit with roughly equals to 1 mm distraction at the osteotomy sign by the rule of similar triangles. Now, a very important component of this deformity is the internal rotation. We correct it by the distal fragment is derotated 10 degrees by shifting this all connecting rods by 1 hole clockwise. Usually 1 hole corresponds to 10 degrees of rotation. But we do this at 2 to 3 weeks after surgery, after some callus formation, because in our initial cases we saw if we correct it at the time of the surgery, many times the fragments get displaced. And the further 10-degree rotation can be done after 1 week as needed. Post-op, when there is a complete correction of the deformity, when both the rings become parallel, and there we always usually see there is a compensatory medial translation of the distal fragment because we applied the hinges extra-articularly. The osteotomy and the hinge site are different, what we call as osteotomy roll 2. The motor unit is replaced by the straight threaded rods. We do a little axial compression, and his frame is removed after healing is satisfactory radiologically, usually average 3 months. We talk about 32 patients For example, this was a 16-year-old male with a cubitus varus of 38 degrees. We applied the Ilizarov frame, we did the osteotomy. This is the pre-op X-ray and the final X-ray. And you can see the deformity, how beautifully it got corrected from this pre-op to final. Another 8-year-old male with left cubitus varus, 13 months post-injury with a 15-degree varus. This is the post-op X-ray. We did the full correction, and this is the final picture and the final X-ray. You can compare both the before and the after pics. Another case, 11-year-old female with a cubitus varus of 23 degrees. We applied the Ilizarov, we did the osteotomy, and we were able to achieve the final correction. And you can compare the pre and the final pics. Another case, 14-year-old female with right cubitus varus. This is the final picture. You can see the final pics compared with the pre-op pics. If we talk about the results, the pre-op values, the mean HUW angle from 10-degree varus, it went to 6 degree of valgus. If we talk about the Mayo elbow performance score, we were able to achieve excellent results in 23 number of cases and good in 7. And to talk about the complications, as with every Ilizarov, there is always a superficial pin track infection. In some cases, we had loss of temina elbow flexion. And in one case, we had this lateral condylar prominence. And in one case, we had valgus overcorrection. To discuss, many osteotomies has been described in literature, the open osteotomies. But the problem with these osteotomies traditionally is there's a no scope of post-op correction, which is very important because more or less this is a cosmetic deformity and patient wants to compare it with the other hand and they want to have 100% correction. There are always chances of recurrence because of the hardware failure because the distal fragment is very small. And the papers have shown up to 30% poor results. Now, these are some of the papers which applied Ilizarov for management of the cubitus varus by Song et al., by Katani, Piskin, and by Bari et al. But in our study, what we found that we took care of a very important component, that is the rotational component, which these papers didn't mention about. To conclude, Ilizarov is an attractive alternative for correction of the cubitus varus deformity because it is minimally invasive. You can always go for the post-op correction to have an accurate 100% correction. You can start mobilizing from day 1, and there is no second surgery for the hardware removal. So thanks a lot. Just have a note, will add a note that it's very important to have to writing a paper, you should have a good record keeping software. This is the software which we use, and you should always have the assessment of your outcome by the functional and the radiological means. Thanks a lot.